Hi, this is Jan Johnson. I'd like to talk to you now about cardiovascular conditions. These can be found in Chapter 11. Part of what I do when I'm getting ready to prepare for a lecture like this is that I review several different board review books. Probably I have about 7 of them in my room right now. I've been reading those. I've been reading different textbooks, trying to get an overview. Sometimes when you're just looking at one textbook, it kind of goes on, and I kind of enjoy things when they're in a nutshell. So this is my version of cardiovascular disorders in a nutshell. Cardiac disease, occurs in up to 2% of pregnant women. The classification of heart disease is usually based on the functional capacity of the heart. It can be reclassified as the pregnancy progresses. The pregnant woman is most vulnerable for cardiac complications from week 28 to 32 of gestation, and in the first 48 hours postpartum. Vaginal birth is usually preferred because there's fewer hemodynamic changes than with a cesarean delivery. Although we will want to note a little bit later, they'll probably want to make sure that this woman doesn't push. She's going to want to deliver via epidural and let what they call labor down, where she's not actively pushing, but they just get her comfortable and allow that baby's head to come down on its own. It takes a little bit longer, but it's better for her in the long run. So after 36 weeks of gestation, labor may be induced if the fetal lungs are mature. Women with cardiac disease can breastfeed if they're careful, and maternal hypoxemia increases the incidence of miscarriage, intrauterine growth restriction, fetal hypoxemia, preterm labor and birth, and stillbirth. Antibiotics are given prophylactically in women with mitral valve prolapse to prevent bacterial endocarditis. Here we have cardiovascular disease classifications, and this is how they affect labor. So class 1 is asymptomatic without limitation of activity, and those patients usually experience normal pregnancy, labor, and birth with no restrictions. Class 2, those patients are symptomatic with slight limitation of activity. Pregnancy, labor, and birth may worsen their symptoms. They need careful monitoring for decreased functional capacity of the heart. Slight activity restriction may be advised, and excessive weight gain should be avoided. Class 3 are patients who are women who are symptomatic with less than ordinary activity, but they're really truly only comfortable at rest. Marked restrictions of physical activity is advised. They can have severe cardiac complications during pregnancy, labor, and birth, and early in the postpartum period. Class 4, these patients are symptomatic at rest. They're unable to perform physical activity because of cardiac insufficiency. Pregnancy would not be recommended because of increased maternal and fetal morbidity and mortality. Major cardiovascular changes during pregnancy that affect women with cardiac disease are increased intravascular volume, decreased systemic vascular resistance, cardiac output changes during labor and birth, and intravascular volume changes that occurred just after childbirth. Now, pathophysiologically, we know, I think you know already, that the blood volume increases up to 30 to 50%, and the pregnant patient's in a hypervolemic state. She shows a 25% increase in her red blood cell count, her volume, and a 50% increase in the plasma volume. So it's kind of unique physiological challenges with these cardiac diseases, but if you look at the RBCs increase versus the plasma increase, what do we see here? We're going to see hemodilution or physiological anemia. And we're going to talk about anemia, especially physiological anemia, a little bit later when we talk about that condition. We're also going to see increased stroke volume and heart rate, decrease in systemic and pulmonary vascular resistance, and there's also a decreased blood pressure. And the patient will be in a hypercoagulability state, and so she's at risk for arterial thrombosis. These are all the cardiovascular conditions that your textbook talks about, and for test purposes, you're really not going to need to know all of them. You've probably, I'm guessing, already studied them. If not, you will be studying them next year. But congenital cardiac diseases, or the left to right shunts, those are atrial septal defect, ventral septal defect. Your textbook gives good explanations of all of them. So for general education, I think it's not a bad plan to review these if you're not familiar with them. You have cyanotic congenital heart and acyanotic. Well, coarctation of the aorta is an acyanotic congenital heart lesion. You have cyanotic congenital heart lesions, which is also called tetralogy of Fallot, which encompasses 4 different conditions, heart conditions. There's acquired cardiac diseases such as mitral valve prolapse, mitral stenosis, and aortic stenosis. Ischemic heart disease such as a myocardial infarction. And other cardiac conditions that your book talks about are pulmonary hypertension, pericardium cardiomyopathy, infective endocarditis, Eismenger syndrome, Marfan syndrome, and heart transplants. And the one thing, it's amazing when I was reading this in your text, it talked about heart transplant patients, how they need to wait at least a year before becoming pregnant. But the exciting thing is, if everything's going well with the transplant and the woman has normal cardiac function at the beginning of the pregnancy, these patients usually do well with labor and birth. Some women develop hypertension and may have at least one episode of organ rejection, which is awfully scary, but it's amazing. I just think it's incredible that heart transplant patients can deliver successfully. These are the kind of things that could possibly be on your state boards, or cardiovascular decompensation. It's recognizing these symptoms to know when a pregnant patient with pre-existing cardiovascular disorders is at risk. So the subjective symptoms that she might present with would be increased fatigue, difficulty breathing with activities, normal routine activities. She might complain of feeling a smothering or a frequent cough. Her heart may be racing. She may present with swelling in her face, in her hands, her feet, and legs. Objectively, she might have an irregular, weak, rapid pulse greater than 100. She might have progressive generalized edema. In pregnant women, especially hospitalized patients, an area that we often forget to look for edema is going to be sacral edema, so it's going to be in her lower back, especially patients who are on bed rest for things like preterm labor and things, but just a FYI. When we're talking about edema, we just don't mean the hands, legs, and face. We're also going to look for that sacral edema. The patient may have crackles at the base of the lungs that don't clear with coughing. She may have orthopnea and increased fatigue, rapid respirations greater than or equal to 25, and a moist, frequent cough. I did notice in one board review book they talked about a dry cough, but the majority of the things said moist, frequent cough, which would go along with some of the crackles. And cyanosis of the lips and nail beds. And I mentioned earlier too, the most dangerous time for cardiac decompensation on a pregnant woman is going to be during weeks 28 to 32 when her blood volume is at its peak. Maternal symptoms depend on the source of the problem, if it's right-sided failure, left-sided failure, or with pre-existing cardiac conditions that I mentioned on page 284 to 288. You may have seen this slide before, but it kind of goes over right-sided heart failure with fatigue, increased peripheral venous pressure, ascites, enlarged spleen and liver, distended jugular veins. She may complain of anorexia or complaints of GI distress, swelling in her hands and her fingers, independent edema. Right-sided failure would include the pulmonary valve stenosis, atrial septal defect and ventral septal defect, congestion in the systemic venous systems. It causes decreased cardiac output to the lungs. The most likely causative agent in childbearing age is the Eismenger syndrome, which is a right to left shunt, meaning the non-oxygenated blood from the right atrium or ventricle leaks into the left side of the heart, causing a mix of the blood being sent out to the rest of the body. This condition is associated with high mortality. 50% in mothers and 50% of the fetuses die. Pregnancy is not recommended in women with this condition, and pregnancy may be terminated if she becomes pregnant due to the poor pregnancy outcomes of mom and baby. Women who choose to continue the pregnancy require strict limitations on activity. if you want to dig a little bit further in Chapter 11, page 287, for further considerations with this. On the left side of the heart, we have paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure, cough, crackles, wheezes, blood-tinged sputum, restlessness, confusion, orthopnea, tachycardia, exertional dyspnea, and cyanosis. These causative agents are usually mitral stenosis, mitral insufficiency, and aortic coarctation. The heart becomes overwhelmed. It has an inability to push blood forward. This causes a back pressure on the pulmonary circulation, causing pulmonary system to become distended. The systemic blood pressure decreases in the face of the lowered cardiac output, and pulmonary hypertension occurs. Pulmonary edema produces profound dyspnea as it interferes with oxygen and the carbon dioxide exchange, where fluid coats the alveolar exchange spaces. They may get frothy sputum, and look exactly like this picture if you've ever seen anybody in pulmonary edema. Cardiovascular disorders show an increased incidence of miscarriage. These patients are more apt to go into preterm labor and preterm birth. They have intrauterine growth restrictions more common. The incidence of congenital heart lesions increase in children of mothers with congenital heart disease. Care management, preconception counseling to understand the risks. If this pregnancy was unplanned, this woman early in the antepartum period is going to require some counseling to explore the couple's desire to continue the pregnancy in light of the risks involved. You're going to want to teach this client to report any symptoms of cardiac decompensation. Remember that big list. Encourage 8 to 10 hours of sleep each night and daily rest periods. We're going to teach self-administration of heparin if it's prescribed. Give the patient a diet plan which includes high iron, high protein, and adequate caloric intake. And inform the patient of anticipated difficult period for control at 28 to 32 weeks when plasma volume peaks in pregnancy. Intrapartum. We want to try to maintain a calm atmosphere, allowing the presence of support persons and keep the family informed at all times. We're going to maintain cardiac perfusion. We're going to put the patient in a semi-Fowler's but sideline position. We're going to prevent Valsalva maneuvers even during second stage. The second stage is when they're completely dilated and they go into the pushing phase, or the baby's continuing to descend the rest of the way. But doing bearing down, like they talk about with the Valsalva maneuver, it obstructs the left ventricular outflow, and this can cause increased stress and cause the mom to have more problems. We're going to avoid hypotension if the patient gets epidural anesthesia. And what we commonly do when we're getting ready to give an epidural is we preload. We give them a liter of fluid just before we give the epidural because it's been shown to lower blood pressure a little bit. Not all patients, but some patients do respond that way by having their blood pressure bottom out, and that's always why we're monitoring them so closely after a woman first gets an epidural. So we definitely don't want this patient to get hypotensive. We're going to avoid stirrups during delivery. That can cause the popliteal vein compression and decrease the venous return. We're going to provide pain relief and supportive measures because pain can contribute to cardiac stress. We're going to monitor forceps delivery and episiotomy. It will likely be performed to decrease the time of the second stage of labor. So what they're talking about is if that baby's not laboring down, if it's not low enough at we'll talk about the station that the baby's at as it descends down into the pelvic, getting ready to birth. And once it gets low enough that they can maybe put a vacuum forceps on, they'll probably, and as long as the patient's comfortable with her epidural, they'll probably do an episiotomy and try to get the kid out that way as opposed to having her bear down at all, because that's just going to be too hard on her system. Postpartum, we're going to tailor the care to the woman's functional classification. We're going to continue semi or high Fowler's position, the head of the bed raised, with the side line maintained. We're going to try to get her on her side. We're going to progress ambulation from dangling to sitting to standing, from short to long ambulation sessions according to tolerance and absence of cardiac decompensation. We want to administer stool softeners as prescribed to prevent straining during bowel movements, and we're going to watch for symptoms of urinary infection or painful urination, white cells in the urine and pus in the urine. Report any symptoms of cardiac decompensation to healthcare providers immediately. Tachycardia being pulse greater than 100, tachypnea, respiratory rate greater than 24 if she has moist cough or crackles in the lung bases. Report immediately any temperature spike above 100.4, and plan with the mother and family for support when returning home. If necessary, refer to community resources for homemaking help or help around the house. Plan and care of implementation. This patient may be on heparin. It's a large molecule drug. It does not cross the placenta. During intrapartum care, the care focuses on promoting cardiac function and prophylactic antibiotics. Again, if she has an infection, we don't want her to get that bacterial endocarditis. In postpartum care, monitoring for cardiac decompensation. Now I'd like to talk about anemia and anemia during pregnancy. Anemia during pregnancy decreases the oxygen carrying capacity of the blood. It affects from 20 to 60% of pregnant women and can be caused by inadequate nutrition, maternal adaptation to pregnancy, and genetic defects in red blood cell production. The increase in blood volume that occurs during pregnancy can lead to physiological anemia. Now, do you remember when I was talking about that hemodilution? Here we have physiological anemia of pregnancy, or kind of like a pseudo-anemia. It's when the red blood cells, they're needed to transport oxygen to the fetus. That's why we have an increase. We have a 25% increase in pregnancy, approximately. And we need those red blood cells to increase because they're going to be carrying the oxygen that's going to go to the fetus. And the plasma volume increase is about 50%. But because the plasma increase exceeds the red blood cells by twice, that causes a drop in the hemoglobin and hematocrit, which causes a state of hemodilution. So their levels are naturally going to be a little bit lower when those plasma and red blood cell levels are at their highest. But true anemia is considered a hemoglobin of less than 11 grams per deciliter in the first or third trimester, or in the second trimester a hemoglobin of less than 10.5 is considered true anemia. Severe anemia is a hemoglobin of less than or equal to between 6 and 8 grams per deciliter. And recently we saw a patient in the hospital, a pregnant woman, with a hemoglobin of 6.6 and a hematocrit of 21. And normally we don't want that hematocrit to be below 33%. Anywhere from 33 to 35%. We really don't want the hematocrit any lower than that. And they were going to give her a blood transfusion, but she refused, and she still had about 9 more weeks to go before she was full term. So it was interesting. I had an opportunity to talk to the neonatologist to see, and the hematologist put the pregnant patient on iron and thought that after a week it's going to come up at least a gram, so that would put her up about 7.6 if she took the iron 3 times a day. Well, a lot of patients who are in that situation aren't compliant with that regimen of taking iron 3 times a day. It's also going to cause extreme constipation for her, and when she already has a baby sitting down there and then you impact her bowel with stool, it can be a very uncomfortable situation. So I'll be interested if we get an opportunity to see how that plays out. But the neonatologist said that iron stores can be replaced quickly, and the baby's going to take from the mom. It'll leave the mom without any iron, but it's going to take from the baby's going to steal the mom's iron from her body to help his or her overall health. So babies can do well with this situation, but the concern comes if she's in labor or if she has any type of bleeding episodes. She won't have enough hemoglobin to help circulate oxygen to the baby, so it could become an emergent situation if she has any type of bleeding. They're not sure also if it was a sickle cell issue, so they were going to be investigating that a little bit further. But very interesting, because she falls definitely in the severe anemia with that hematocrit of 21 and the hemoglobin of 6.6. Now I'd like to talk about some of the different types of anemia. We have iron deficiency anemia, which is the most common type of anemia during pregnancy. It carries with it an increased risk for infection, delays healing time, and decreases energy for the postpartum period. The fetus will receive the necessary iron for growth and development, while the maternal iron stores become depleted, leading to symptoms of anemia. This is common when women don't want to take their prenatal vitamins that have extra iron, and especially if they're iron deficient. What happens is that they end up getting a permanent depleted state, and it can take them a very long time to try to recover and get that strength back postpartum. But the baby will get what it needs, but it leaves the mom kind of empty and feeling horrible. Treatment includes dietary counseling. They're going to be taking supplemental iron. We really, really, really need to educate these women, remind them that the iron is going to assist with oxygen transport and carbon dioxide transport. It aids in the production of red blood cells. It plays a big role in the body's immune system. So we're going to talk about pica. Pica is when the woman has abnormal cravings for clay and things that are not edible. Iron supplementation is going to be important that they maintain that and they don't forget their iron supplements. Women can be transfused with IV or IM. IM hurts tremendously, so normally they're just going to take it orally. We want to make sure they're taking their prenatal vitamins, and we're going to want to increase in their diet with meats and green leafy vegetables. Remember that iron can cause severe constipation, so we're going to want to make sure that they have a stool softener or something to help. Folic acid deficiency. Folate's a water-soluble element. It's found in green leafy vegetables, citrus fruits, eggs, legumes, and whole grains. It's a common deficiency, especially in pregnancy, due to the increased fetal demands and because it's less well absorbed from the GI tract during pregnancy. The recommended intake of a non-pregnant woman is going to be 400 micrograms per day, where a woman who's pregnant is going to be 600 micrograms per day. Without it, with a deficiency, these women are at risk for neural tube defects. And the CDC recommends all women of childbearing age take extra folic acid. It's the most accurate time before pregnancy, in early pregnancy, to help with spinal cord development. Thalassemia is a congenital disorder in which there's a defect in the hemoglobin formation, causing a shortened lifespan of the RBCs. It's usually seen in people with Mediterranean or Southeast Asian descent. There's two different categories. It's really called beta thalassemia, and there's beta thalassemia minor and beta thalassemia major. Minor is when they only inherit one gene, and it doesn't really have a huge effect on pregnancy. The major, though, that's also called Cooley's anemia, and that's where they're inheriting a gene from both parents. It's much more serious. Usually the woman's infertile. Those women often die earlier in life due to infection or cardiovascular complications. They have lifelong issues with hemolysis, anemia, and they risk premature death. If they do reach childbearing age and get pregnant, medical care is much like sickle cell during pregnancy. In this slide, I tried to compare and contrast a little bit sickle cell during pregnancy when a woman has the sickle cell trait or when she has the actual disease. So it's from sickling or abnormal shape of these red blood cells. The normal, when someone's carrying a trait, they have sickling red blood cells, but they have a normal 120-day red blood cell lifespan. Those patients are usually asymptomatic. They do require genetic counseling and partner testing because we want to see, especially preconception, because we want to see what the risks are, and we all did that. We've all done those Punnett squares, so we know what percent chance they have of actually carrying the trait, or whether they have a chance of an offspring having the disease. These women, though, even though they're carrying the trait, they're still at risk during their pregnancy of preeclampsia, an intrauterine fetal death. That's what IUFD means. Preterm birth, low birth weight infants, postpartum endometritis, increased urinary tract infections, and a decreased iron. Sickle cell disease, their average lifespan is only 5 to 10 days as opposed to 120 days. It occurs in 1 in 708 African Americans in the United States, according to your text. These patients have recurrent recurrent crises, usually triggered by dehydration, hypoxia, or acidosis. They require genetic counseling due to poor pregnancy outcomes, miscarriage, intrauterine growth restriction, and stillbirth. We're going to monitor for preeclampsia and urinary tract infections. They're going to do serial ultrasounds on these patients to assess fetal growth and development. Anytime this woman comes down with an infection, we're going to want to treat it quickly. Anything that could cause dehydration or hypoxia or acidosis. When she's laboring, we're going to keep her on her left side, keep her well hydrated, and give her extra oxygen.